Hello, everyone. This is Ed Breniger, and welcome to the Eddie Network podcast. My guest today is Dr. Mel Thacker, and she is a surgeon. And I welcome you because you have made some changes in your life and you have become very vocal about some things, which I really have a deep respect for and look forward to having conversation with you. So thank you very much for being here.
Thank you for having me.
So tell us a little bit about who you are and what you do, and maybe how you got into being a surgeon.
Okay. My name is Mel Thacker, and I live in Massachusetts. I'm an ear, nose, and throat surgeon. Um, and I've been doing that for the last 12 years. And I walked away from my practice last December, so about a month ago. Maybe for good, maybe not. I don't know. We'll have to see, but I'm giving myself a year to kind of figure out what my next move is going to be. But the way that we practice medicine in this country just became untenable for me. And I realized that there was really no option other than leaving. And the reasons why I left were threefold. So I took the courageous action to walk away from a very successful practice that I created for myself. I have built a reputation. I take excellent care of my patients. I'm an excellent doctor. I'm an excellent surgeon. And I love what I do, but I can no longer do it in the way that I would like to.
Can you be more specific about what that looks like? What that conflict that brought you to a point of decision of transitioning out of what you were doing?
Yeah, I think to answer that question, I'll kind of like paint a picture as simply as possible in the way that we're employed or the way that physicians work in this country. There's essentially three practice models. You have pure academic, where you are compensated not only for your production, taking care of patients, but also for scholarship, for teaching, for research, things like that. That's part of your compensation package. And you typically have some sort of title like assistant professor, associate professor, and then you move up to full professor, and then you can sometimes seek out tenure as well. So that's kind of the academic model. I started out in kind of a pseudo academic model when I came out of training, and I realized it wasn't for me at all because the problem with academics is that it's very dog eat dog. There's a lot of politics. It can become a popularity contest. That's one piece. The other piece was I realized I really value my own autonomy. And so you don't have a whole lot of autonomy in the academic model, meaning that if I wanted to change a clinic, let's say I wanted to go to one of my kids' like plays or something, and I decided that a week prior, I couldn't do that. I'd have to decide on something like that with a 30-day advance notice in order to change my clinic schedule. So I couldn't just unilaterally say, hey, cancel my afternoon, for example. I would have to go through all this bureaucracy in order to make that happen. Or if I needed like a new piece of equipment, I'd have to kind of lobby for it and go through all these layers of bureaucracy in order to get it. So it became very clear to me that I hated that. And I also am not a big person who's in research. I don't want to do any research. All I wanted to do is take care of patients. I'm just a clinician. I love clinic. I love interacting with patients. I love operating on patients. I love helping them. And so the next model I sought out which was private practice, and that's another model. And in private practice, you are essentially a business owner. And so it really helps you, it behooves you to have some sort of business acumen to understand the business of medicine, which I didn't. It was kind of like just learn as you go. And we'll go back to that. But then the third type of practice model is perpetual employment. And that's kind of what most physicians end up in. Back many decades ago, 70% of practicing for physicians were independent. But now it's flipped. There's 30% are independent and 70% are employed. And in perpetual employment, you basically say, hey, I will do the medicine part or the surgery part, and I'll outsource all of the other stuff to powers that be. It could be private equity is now kind of sweeping over the corporatization of healthcare. Um, and you outsource all of the back end stuff to other people, and you kind of give them all the power to make all the decisions as well. And that's where it becomes a problem because the people who want to make decisions are trying to maximize profit. They're typically business people and they care most about creating profit. They don't care so much about the patient. They don't care so much about the nuances that happen in the clinic, that happen in the operating room or happen in the ER. And so I thought I would be okay in private practice because I thought I would have some autonomy. And it was fine for a while. I started there in 2015 and I built my practice. I became very busy. I became partner. So I was a partner in my three-woman practice, my three-person practice. There was a male at that time. He retired. And then we eventually had a two-woman practice and then a three-woman practice. But it became more evident to me that I had less and less autonomy. And it's almost like death by a thousand cuts because it's a million little decisions every single day. It's like prescribing a medication and then you have all these roadblocks. You can't give the patient the medication you want to prescribe them. You don't know which patient has which insurance that will have the formulary of whatever medication. And I found myself trying to explain how healthcare works to patients more than I was really like doing my job. I couldn't just operate on patients when I saw fit. I would have to basically split my brain when I'm talking to a patient and have one side of me thinking, what's the right thing to do for this patient? And then the other half of my brain was thinking, how do I communicate that to the insurance company so I don't either get denied or have to get on the phone and do all this work to try and convince them that this is the right thing. And all of that is just so mentally taxing. So it's you see someone, you're with them, you get to know them, and with your judgment and your training, you say, I think you need, this is my recommendation, this is my plan for you. Either it could be lifestyle, that could be an option, it could be medication, it could be surgery, or it could be a procedure, depending on where they're trying to go. And then instead of it just being like, okay, that's great. You guys leave and like that's the plan. Now you have to fight for your plan. You have to fight the pharmaceutical company, you have to fight the insurance companies to make that plan. If you multiply that by, 20 to 30 patients a day, it starts to kill you. It's like soul murder. And then add on top of that, after the fact, because I can see behind the scenes and I see how we're paid, sometimes you get compensated and sometimes you don't. And sometimes you get compensated and then months, years later, the insurance company claws it back.
Mhm.
And you don't have any control over that. So it's just so like soul crushing.
Yeah.
And it makes you feel very undervalued. So that's why I left.
Well, as a patient, and I've had I've had a lot of interaction with the healthcare system here over the last 3 years uh, because of acoustic neuroma this ear, where I lost hearing in that ear, developed vertigo, and then developed um, basically an arthritic hip, which led to a hip replacement. But on top of that, I had something going on in my lower spine, but it wasn't in the spine. But there was something going on where uh, I would stand up and in certain instances my legs would go numb immediately, and then I would sit down and they would return. So there was something going on with a nerve, and it was really strange. And so I was going to see doctors, going to see physicians. So I had a hip doctor and had a spinal doctor. I had an ENT, and then I have a, a, a neurosurgeon ENT. And I have this collection of all these doctors plus a primary care physician. And um, and so I've been interacting with all of them, and with my health care. I mean, and I'm retired, so I'm on Medicare, so that is a little more complicated as well. So I understand what you're going through, and what I realize is that if you're the patient, you're really at a disadvantage because there's so much information trans being transmitted between you and your employer and the healthcare, I mean, with the health insurance company, and all of that going on. The patient really doesn't must have to trust their doctor if they're going to get through it with some kind of peace of mind. And so that collection of relationships to me seems really problematic today. And and I don't know what the answer is, but when you wrote about the moral harm of what you were going through, I realized that there's a level of that patients are going through as well, because they're being placed in a situation where they have to make decisions about their health care without maybe without with inadequate information, because they don't know what actually is going to be permitted for them. It's a very complex and difficult situation to navigate for, fortunately, I'm just one of these people. I'm going to do all my research and I'm going to go in and I'm going to be very clear about what my expectations are. But I'm seeing people sitting there in the outer office waiting to go in, and I know they don't know even why they're there. And I really feel for them. So you are in a conflict situation, and the patient is too. And we're all trying to get healthier, and it's a real challenge.
Yeah, I mean, there's many layers to that, and there's many places we could go with that. But yeah, the patients are hurt, the physicians are hurt. And because we're the first face that people see, we might be the ones that they blame. I mean, maybe we're distracted. We've been forced by our employer, who was bought out to private equity, to see 35 patients in a day. And typically we only want to see 20 because we like to spend time with people,
Yeah.
but we don't have any control. And so maybe we're behind and we're trying to catch up and our souls are murdered.
Yeah. Yeah.
We're spinning in confusion and overwhelm and we don't know what to do next. We feel trapped. Obviously, that kind of a doctor isn't going to connect as well with a patient. And meanwhile, they're trying to check off all these boxes that you have to do for the medical record because there's all these layers of regulatory stuff, these bureaucratic layers. And that's what the patients see. And they're like, oh, my doctor doesn't care. And so they get mad at the doctor and they complain about the doctor. And then they go on Google and write a bad review. And it's just like this cycle that doesn't go anywhere for anybody. It morally injures the doctor the way the system is. It's morally injurious for the patient. And I mean, the bottom line is that $750 billion of healthcare dollars are wasted on bloated bureaucratic layers, on the bureaucracy, on the admin, and unnecessary testing. Okay. And so if we had all of that money and we put it into elevating the physician-patient relationship and making that the center and really honoring that and saying like, that is the most essential thing. How do we protect that? How do we make sure that however the physician and the patient have to connect so that the physician and the patient can have a shared decision-making conversation and come to some sort of plan that makes sense? And that's all that matters. How do we protect that? If we threw all our money on that, then everybody would be so much happier and healthier. But we don't. We're just trying to create layers of regulation and bureaucracy to keep people, quote unquote, safe. Okay. Like taxing, for example, if you go to the emergency room, anybody who's been to the emergency room might notice that the triage nurse will ask you, like, do you feel safe at home? Because they've been taxed with having to check a box that shows that they're screening for domestic abuse. Now, while that's all fine and good and that sounds good, it's nobody who's in a situation where they're being abused at home is just going to meet a triage nurse for the first time and say, well, actually, yeah, I am. And then what are they going to do about it? It's like it's so much more nuanced than that. We can't put all of these all of these requirements on healthcare workers, and to keep people safe, we're supposed to keep them safe financially. We're supposed to keep them safe at home. We're supposed to keep them safe and healthy. We're supposed to keep them all of their preventative things in order, making sure they get their colonoscopies and their mammograms. And if they don't, it's like it's on the physician, the clinician. But what ultimately has to happen, like you cannot regulate that and turn everything into a checkbox. You just have to develop relationships. It's so much different if, let's say, a nurse and a patient became very close because they had talked and they connected. And then the nurse said, like, hey, are you okay if I ask you about those bruises on your face? And then maybe the patient would be receptive and start crying and say, actually, yeah, I am being abused at home. And then you can open up a conversation for that. But the way that it's baked into the system is a checkbox that everybody is just like, oh, I have to ask that question. Boop. Hey, did you get your mammogram? Boop. Do your kids eat fruits and veggies? Whatever it is. And it's like, it just falls on deaf ears and nobody's having an honest conversation. And so I think we really do have to kind of destroy the whole system. We have to creatively destroy things like that, these these regulatory or bureaucratic requirements that are just mind numbing and not useful. And then take all of the money that we're spending and really spend it on just protecting and elevating that patient physician relationship or that patient clinician relationship. That needs to be the number one thing that we look at. How can we not tax that with stressing out the doctor? How can we not tax that with stressing out the patient? How can we make it easy so that those humans can come together and then have a real authentic conversation and develop a relationship? That's how we make people healthier, and that's how we make doctors happier, I think.
I totally agree with you. And I like going to see my physicians. I really do. Because I'm going in with questions. And I had a urologist 20 years ago that I started going to see, and I started asking him questions. He says, "Oh, that's a good question. Where did you find that out?" And what he told me was he's so busy he doesn't have time to keep up on the research.
Mhm.
And I said, "Well, I'll keep studying and I'll keep telling you what I'm learning, and if it helps, that's great." So we had a little partnership going on. Um, and then I moved, and then I moved again, and I'm now back in my hometown, and I'm making it very clear. So for example, um, I went to see this one new physician, and I saw his PA, and she walked in, and I could tell she had a script going on in her mind, and um, and I'm not faulting her for that, but
Right.
that's what happens, and um, and she was slightly condescending towards me, and that's fine because I'm going to win her over. So I started saying, "This is my experience. This is what I'm going through. This is what I think is going on, but I don't know. What do you think?" And she said, "Well, I don't know, but that's really helpful." And so I was helping her do her job better by being really informed, by having um, figured out how to articulate what I was experiencing in my body. Um,
Hmm.
then I went to began to go see a new primary care physician. And I'm sharing this story because I think I want people to understand that they can talk to their physicians one to one and and not be intimidated by it. And so was really interesting. So I go to see her for the first time, and they take my blood pressure, and it's elevated, and she's concerned about it. And they look at my blood, and she's concerned about it. So she wants to put me on a blood pressure regimen. She wants to put me on drugs. I said, I'm not interested in doing that. I'm gonna address this from my lifestyle. So give me
Hmm.
2 months. And,
Hmm.
and I went back after 2 months, and things were much better. And she was pleased with that. She allowed me to do that. because I didn't say it out front, but I said, if you do not allow me to do this the way I want to do it, I'll get a different care physician, which would not
Right.
look good for her. So I wanted her to be my partner in this. And so I went to see her, and I realized that I have a blood pressure cuff here, little one of these little things, and I check it regularly, and and I also give blood at the Red Cross, and and when I go to the Red Cross, they do a manual blood pressure check where I'm doing at home, I'm doing a mechanical, and they come out differently. So the day I went to see her the second time, I spent 2 hours in the morning checking my blood pressure using both arms, keeping a record of what I went through, what I was having, because 2 hours later, I was going to go get blood. And the blood pressure at the Red Cross was lower than all the 8 blood pressure measurements that I had done that morning. And I laid that before her and I said, I think that I do not check well with using the machine. I want you to use the manual uh, check, from here on out.
I think it's
And
called the sphygmomanometer, which is
okay,
a crazy.
right. So
Yeah,
okay, that I'm
if I
glad to
remember
hear that.
correctly.
But but I showed her the numbers, and she says, that's really interesting. And then and before I'd seen her, I saw one of the I don't know what the term is, one of the technicians, and I
Medical assistant.
medical assistant, and I told her what I was going through. She said, yeah, we do find that fairly regularly with people. So, but what I'm saying is that it is possible to have a really positive relationship with your physician if you want it. And what you're telling us is that you want that relationship with us. And and sometimes the system gets in the way of that.
I'm saying that not only do I want that relationship with patients, it's necessary for me to do my job. I
Yes.
can't do my job without knowing my patient. Okay, because patients are human beings. They're not recipes that you cook. You can't just go to a book and say, okay, all your symptoms fit here. And so now you fit in this box. And so here's the treatment algorithm. Here you go, patient. You have high blood pressure. You get a blood pressure pill. No other way to do it. You have to say, okay, what is the data we have? Well, blood pressure is high. It's consistently high. Okay. Are you willing and ready to take a blood pressure pill for the rest of your life, patient? And then Ed, you would say, actually, I'm not. And I would say, that's important. I need to know that. Thank you. That's really good to know because now we have to think about this another way. Are you willing to initiate some lifestyle changes? And you say yes. And I'm like, great, equally as effective. Now we're talking in a different way. I would not be able to make that decision if I didn't have a relationship with them. Okay. So there's so many factors that go into coming up with a plan for a patient that it's impossible to just look at your guidelines. Like insurance companies just look at guidelines from data from way long ago, known knowns, things that we know for sure that have been studied. And they go, okay, well, from this study, we know that this treatment is appropriate. And so that's the treatment that they should have. And so, like in my world, oftentimes I would be forced basically by insurance companies to prescribe antibiotics that were unnecessary. And so I would have to have these conversations where I'm like, I'm not going to destroy this patient's good and bad bacteria. I'm not going to give them something that wipes out their microbiome when I know it's not going to fix their problem.
Right.
Okay, that they told me this is a problem worth solving, and I know the way to solve it is with this surgery. And so I'm not, and they're like, well, you have to do another round of antibiotics, get another CAT scan, and then you can talk about surgery. It's kind of like that, where it's like you're asking me to give this patient an unnecessary medication that could potentially harm them and radiate them unnecessarily. And so that's moral injury, where I'm basically saying, this is what the patient and I decided because of our relationship and because of all of my years of experience from doing thousands of sinus surgeries, from seeing thousands of patients, from a very long, rigorous multi years, a decade of training. And this is what I have come to. This is the solution I've come to. This is my opinion as an authority in the field. And I have someone who's not even in ENT. Sometimes maybe they are in ENT. Who knows? Could be a pediatrician, could be, could be a general surgeon, could be anybody. And they're like, well, but my book says that you have to do it this way. So you're denied. And that's flipped on its head. It's opposite of the relationship determining the plan. And I think if the relationship determines the plan, then everyone would be better off. But we completely deny. We don't value the relationship. We don't, the system doesn't value the relationship.
Right.
Um, the way that physicians are compensated is through CPT codes, for complexity of care, and procedures. So it's like the more you do, the more you diagnose people with, the more medications you prescribe, the more procedures, the more things you order, the more you're paid. You're not paid to do less of that and build a very close relationship when that is how we create healthy humans. It's no wonder we're the unhealthiest country in the developed world, yet we spend more than all of them.
I would like to ask, the question, is there a way out of this? But I'm not sure that there is at this point.
Uh, Realistically, I think it's going to get really bad. I think people who are like-minded, like me, I just happen to have very low tolerance for suffering. If I'm like this, I am internally divided. Part of me is like, this is how it should be. But then external to me is like, well, you don't have any choice there. This is the way it is and you can't change it. Then I am going to leave. I am not going to sit there and suffer. Whereas a lot of my colleagues, a lot of my friends, a lot of my partners are just like, well, I guess this is the way it is. I'll just put my head down and do my best, and hopefully I'll make a paycheck and get my kids to college and have enough for retirement. And they just put their nose to the grind and do the work and just don't think about it. And they become complicit. Essentially that's betrayal blindness. They choose to be blind to the betrayal of the system because it helps them get up in the morning and do their jobs. And thank goodness for them, because then we wouldn't have any doctors. But if we keep pushing good people like us, keep pushing us and pushing us, I am just a canary in the coal mine because, like I said, I have very low tolerance for suffering. So I go first. And if, as a 44-year-old woman who is at the top of her game, walking away from surgery, then how many other people are going to follow me? I'm just kind of like the quick start. I'm the innovator. I'm like the best buyer. And if you look at like business world, I'm always the one who's like, yep, I see it. Okay, let's go.
You're a
But
leading indicator.
I'm a leader. I do these things. But as it gets worse and worse, I think a lot more people are going to reach their breaking point, a lot more physicians, and then they're going to leave. And there's going to be no doctors. And we're going to have to scramble. And we'll probably try to bring in doctors from other countries, which will keep us afloat a little bit. But I think ultimately, and I don't know, but maybe I think everything could implode and collapse. And I think the only way to maybe force change is for every doctor to just stop contracting with insurance companies. If we don't contract with them, they will fall.
What was the response from your colleagues when you decided to do this? What were they saying to you?
I don't think they told me what they really think, so I don't honestly know. But
Huh.
I think I can't say for sure. I think they knew it made sense, and I think because they know me and they see everything I do. I am an innovator. I am someone who will take action when I see something isn't working and try to make it better. I think it made sense to them. They're like, yeah, that sounds like something you would do.
How young were you when you had the first inclination that you wanted to be a doctor?
13.
Was that like a dream for you?
It was a decision. It was like, this is what I'm going to do.
And do you feel that dream is being lost?
No, I don't. I mean, I think I had a great career. I loved it. It was amazing. I'm not angry about it or upset about it. This is just the way it is. This is something we all created. This didn't happen in a vacuum. This didn't happen by some villain who is like, I'm going to hurt people. This is something that we all created by acting like humans,
Hmm.
by basically taking action from fear and anxiety
Yeah.
and adding in new layers of bureaucracy without thinking. We did it without thinking. Oh, okay, wait, how important is the physician-patient relationship? No, we just think of let's avoid this horrible thing from happening by putting in this layer without thinking of how that could be mentally taxing for the people who have to implement it. And let's just put people with MBAs in charge and insurance companies in charge who are trying to maximize profit, which is what they do, without letting them see the effect of that. It's not like you have an executive in an insurance company who's going into a hospital or a clinic and saying, like, let me see exactly what my policies and procedures are doing here. I don't think they would make the same decisions if they could actually see what was happening, if they put their boots on the ground and looked around. But we decided to separate it.
Yeah. Well, it's really clear. But that mindset is something that's happening across the board in business. So it's not like it's just healthcare that suffers. There is, I think the term that I've heard is financialization of every facet of a business. So every
Yeah,
facet
well,
of business has to generate income, and
it's
therefore,
Welchian, right? Welchian economics, Jack Welch with like GE.
yeah, yes, yes,
It comes from that.
that's
So if we've idolized the almighty dollar, then obviously that's going to be at the cost of relationships and service.
Do you think? I'm asking this because I have a particular perspective of it. Do you think that we're at a transition point where if we don't change, then things really will collapse?
I mean, I can't predict the future, but all I know is my defense is to stay healthy.
Yeah,
And I mean, if you can stay healthy and not get old, like that's great. That would be the best thing you can possibly do.
getting old is no fun.
I want to avoid doctors and hospitals at all costs. That's my defense because
Yeah.
not that I have a mistrust, but I know too much. And I'll actually be speaking about this in an upcoming TEDx talk, but I recently had to go to the hospital with my son because he had unrelenting abdominal pain.
Hmm.
And I tried to sit back and just be the mother and not intervene and let the system do its thing. And so they, worked him up with labs and worked him up with ultrasound and looked for all the common things like appendicitis, testicular torsion, all of the things. And ultimately, they couldn't find anything. It was inconclusive. And then he passed some gas and he felt better. And he was like, I feel great. But at that point, we were already in. And so the ER doctor was very committed to finding a reason why he had abdominal pain in the first place objectively. She needed a lab or a diagnostic study to prove it. And so she said, either you leave against medical advice and then you have to shoulder all of the cost of this visit because your insurance company won't pay for it, or you allow me to transfer your son to a higher level of care, ambulance him to a different hospital. And that was where I was like, okay, now I'm going to speak up. And I was like, you are not making a decision for my son. You are making a decision for yourself because you need to have the objective data to explain his abdominal pain.
You know that
You're
you're,
At that point, she did. She asked me at that point, and I said, "You're ignoring the fact that he is completely asymptomatic now, and that is important to know. That is a black swan. That is an unknown unknown that has presented itself here, and you're ignoring it because you are too afraid. You're playing cover your ass medicine, and you're afraid you're going to send a kid with appendicitis home, or you're afraid you're going to send a kid with testicular torsion home, or you're afraid I'm going to sue you. And so you're trying to cover your ass and make sure you get all of the information so that none of that happens." I was like, that is not for him. That is for you. I'm sorry, but testicular torsion doesn't go away with a fart. Neither does appendicitis. And so once I like kind of voiced my place, she kind of took a minute and she like looked at me and was like, and she was like, all right, I'll let you go home. But because I had that information and I could see inside her brain and I was articulating to her what was happening in her brain better than she understood it herself, she took the time to say, you know what, you're right. That's exactly what I'm doing. And that's not fair because that's wasting money on an ambulance ride. That's wasting money on a subspecialty evaluation at another hospital. That's inconveniencing your family. It's already late. My son hasn't eaten. I have a little girl at home. Who knows how long that whole saga would have been? It would have been an all-night saga and the suffering from that. So there's financial suffering, there's just like inconveniencing. And I was basically saying, you're not giving us a choice. You're giving us a choice between paying tens of thousands of dollars or causing us inconvenience, and you're adding more financial burden to the system for no reason. I was like, that is not a choice. And so she did the right thing and she discharged us. That was last November.
It sounds like a scene from House.
Yeah, but isn't that fascinating? Had I not had that inside knowledge, like what would a regular patient do? They would say, okay, if you're afraid, then yeah, ambulance my kid.
Yeah.
Or it was somebody who was like, no, this is ridiculous. I don't trust the system and I don't trust your judgment, doctor. Then they would angrily grab their kid and leave, and they would be saddled with a $20,000 bill. It's just not fair.
Do any of these medical shows depict an accurate picture of healthcare?
No,
That's
no.
that's what I figured. They're all for entertainment
Yeah,
and conflict between personalities and stuff like that. Yeah,
right.
that's the build. That's the way they build their stories. Um, and yeah, uh,
I don't watch them that often. I haven't in a while, so I can't say for sure, but from my experience, I would say no.
well, they're romantic dramas, what they are. You know, in
Yeah,
many
it's not romantic trying to fight to give your patient the right treatment.
no, it's the romance between the characters
Yeah, yeah.
or the false romance or whatever it may be. So you have decided to become a coach, right?
Yes. Yes, I have been a coach for a while.
Talk
And
about
I've
that.
yeah, I help surgeons find their way through the fog and get through the overwhelm and find some clarity. And rediscover themselves and find out who they are underneath all of their surgeon identity and drop a bunch of cultural narratives and paternalism and positioning, and ego and all of those things, and again, in like the fear-based decision making, which was what I was seeing in the emergency room. And I help them kind of manage their minds and manage their emotions and take aligned action that feels true to them so that they can ultimately look back at their life one day and say, like, that was my life. Like, I'm so proud of my legacy. I had a positive impact. We all want to have a positive impact on
Yeah,
the world,
right.
and they can. They just have to be okay where they are first. Stop holding the victim mentality. That was really hard for me. It's really hard to not vilify a system and feel like a victim,
Mhm.
but I recognize that that wasn't useful. And so helping my clients do that is a really essential part in helping them build a self-concept so that they can create whatever life they want, whether that's being a surgeon for the rest of their life or doing something else, whatever they want to do. Doesn't much matter where they are. They get to follow their heart and their dreams and create whatever life they want to create.
I would like that to happen for the physicians that I know. I would like that for them, and many of them. I don't know how much they feel like they compromise that. They don't reveal that to me, but I do find that they're very attentive to the relationship, and that's why that really matters to me. I mean, it's number one. What is the relationship we have, and how can this relationship mutually benefit each other, and because I know when I talk about what I'm experiencing, I'm giving that physician information that they're putting into their own mental database and comparing that to other stories that they're hearing. And I'll give you an example. When I first lost my hearing, which was in September of 2021, I went to a physician and had blood work done, found my blood work was fine, and asked for a recommendation for an ENT. And they said, well, you need to go see this ENT. And I was living in a different town, and it sent me to another town, and I went to see this person. And and at that point, they did not know that it was an acoustic neuroma. They just knew that I had lost my hearing. And it was sudden. I mean, it was like bang, it was gone. And and I was despondent. I mean, you see me here. We're having conversation. This is the way all my days are. And I'm thinking, if I lose my hearing, my life is over.
Right.
That's still true. That's still true. And so and the day before I was supposed to go meet this guy, the vertigo happens, and it's bad. I mean, I have to go to bed, and I get my neighbor to take me to urgent care, and they prescribe me the meclizine, I think it is, and that helps, and I'm okay. I mean, but I'm still all over the place. I mean, just doing that just destabilizes me. So I finally get to see him 2 months after this happens, and he he says, "Well, within a month," he says, "I think what I want to do is treat you with antibiotics." And so they did over a 3 week period. They did 3 injections of antibiotics.
No, they didn't give you prednisone? Hmm.
That's what they did, and it was injected straight into the ear canal, you know. And
He was probably injecting prednisone, Decadron, maybe.
could be.
And
I don't
probably
know.
steroid. It was probably steroid.
Oh, it was a
Or maybe,
steroid. That's right. It was a
yeah,
steroid. Sorry, I'm getting
all
my
good.
not a physician.
Common.
And so, um, between the second and third, I have an MRI, and that's when they
Yeah.
determine, okay. And after the third um, injection, I get home and I end up sleeping 12 hours a day for the next 2 weeks, not eating. I mean, it's just this reaction was, and then I wake up. I mean, this is Christmas 2021. I wake up basically on New Year's Day, and I feel like I'm back in my 40s, energetic, fun. Still don't have any hearing, still don't have any balance, but I feel great. So I go tell him that. He says, and at my next visit with him, he says, huh, I think what you're telling us means we need to change our protocol. I think we need to do the MRI earlier than what we've been doing. Thank you. So, it's that kind of, so maybe what I was sharing with him is helping someone who's coming after me to maybe have a better outcome for their loss of hearing or whatever they're going through. And and I see that is how we are all connected. And we tell our stories and we share our suffering and
Mhm.
we share our joys. And we somehow get through it all.
Yeah. And it's the relationships that's at the center of all of it. And it's wonderful that your ENT doctor had the freedom to decide on what kind of protocol that he
Yeah.
wanted for his patients. And that's what we need to preserve.
Yes, he did have that freedom. And he was old, he's older, he's about my age. And so he decided he could was if I was going to require surgery, he wasn't going to do it. And so he sent
Yeah.
me to this young neurosurgeon down here.
Neurootologist. Yeah.
And and he's been fantastic too. And, and he's we have talked and we have shared our I've shared my experience with him, and he's let me make my decisions. So I have, in a sense, had the experience with my physicians of what you would like to have had with all your patients.
Yes, and I think everyone deserves that.
And
The
I wish
patient,
that for you. I wish you could find a place where that is true because you're obviously, you're a caring physician and we need you caring for people.
yeah. Yeah, patients know their bodies. We're merely consultants. We don't know more than the patient knows. We have a little bit of information and we can help guide them. And we
Yeah.
can say, hey, if it were me, this is what I would do. If you were my loved one, this is what I would recommend. And that might make the decision easier if we're honest, but it's
Yeah.
ultimately not our decision.
Yeah. You don't have that. You're not able to make that decision. That's what I see. Well, maybe, I don't know, maybe you're you're moving out of being a regular physician and becoming a coach to physicians, to surgeons. Maybe that'll have an effect. I don't know. That's my hope.
I'm hoping because I think if surgeons are better resourced and they're not just treading water trying to get by, then we'll be much more likely to come together and say like, hey, this isn't okay. We're not going to stand for this anymore. And once we're together collectively, standing in unison, that is when we can get the ear of the higher ups, go above the insurance companies. It
Yeah.
has to come from, it has to probably be literally an act of Congress, right?
Well, we got a new administration and who knows what's going to happen there.
We'll see.
We'll
I
see.
don't know.
Well, it's been really great to have you. Um, I wish you well in this new venture. I'll connect you to some surgeons. I'll connect you to my surgeons because I want them to know about you, and we'll kind of see all this goes with you, and whatever you know. I mean, the when the podcast comes out, which will be sometime in February, I guess. I don't have the schedule before me, but it will be something you can use to send out to people. Say, hey, here's the conversation. Here's one conversation we had about what we're doing and what I'm doing, and maybe it'll create a movement of people
We'll
who
see.
we could always hope, right?
Yeah, I do hope so. I hope this doesn't become like a flash in the pan thing and then we all just go back to the way it was and it slowly gets worse.
Well, we're not there. I think COVID changed everything, and I don't think anyone is willing to go back to where we were. And so the question is, where do we want to go? And that's what I see people asking that question. And you're speaking about a place that we can go to. And I
Mhm.
think that's really important. And so
Yeah.
I am I am more optimistic today than I was 2 years ago. So so we'll see. I mean, nothing's inevitable and nothing's certain, but I think people are better informed than they used to be, and that's a good thing.
Yeah, I agree with that.
And we'll certainly put whatever information we need to put in the show notes for you. If you'd also send me a picture, or I can take a picture off your website. But so we have some information to.
Yeah, I'll send you a bio and you can find me. I have a podcast, Surgeons with Purpose is my podcast, and Instagram is where I do most of my social at the underscore surgeon underscore coach.
Yeah, we never did talk about this thing.
We talked about it a little bit.
How about Yeah, this is really great that you did. I think that's the kind of
Yeah.
thing that helps. I mean, obviously, I took pictures of all of this and then transferred it to a piece of paper, and I'll
Uh,
carry this around with me.
there you go. And there's a book called If I Betray These Words, Moral Injury in Medicine, Why Clinicians Can't Put Patients First, I believe is the whole name of it by Wendy Dean that goes through all of the reasons why physicians are really suffering. We're not burning out, we're morally injured. And so that book is definitely one I would recommend everyone read.
I think that idea about moral injury is why I contacted you. That, and that is true in many sectors of the world today. And
Mhm.
we can now talk about it. And I think that's a good thing. Well,
Yeah.
thank you very much. This has been
Thank you.
fantastic. And let's do it again because
All right.
there's a lot more I'm sure we could mine from this area of life.
Absolutely.
And I thank you all for watching. Um, Make sure when you go see your physician that you have a conversation and not just listen, but actually share with them what you're experiencing and think about it. And if you need to, write it down before you go. I mean, keep a little notebook with you. If you're suffering from some kind of physical ailment, keep track of what you're actually experiencing so that your physicians can be very much attuned to who you are and what you're experiencing. So I'm right about that, right?
Absolutely. Yeah. And I hope if you're a physician, please give your patients your ear, give them your presence.
Okay. Well, thank you everybody for watching the Eddie Network, and please subscribe, hit the like button, and leave a comment if you will, and we'll see you next time here. Thank you very much. Bye bye.